Hello everyone, this is Dr. Yashar Basha. I am consultant andrologist from Istanbul. Today I would like to talk about 1 year follow-up results of one of my patients who got selective dorsal neurectomy 1 year ago. You know that we are the highest volume center to perform interventions for premature ejaculation treatment in European zone. If you are searching for interventional treatment of premature ejaculation, probably you come across with us, and today I would like to tell you about the result of a neurectomy patient that we performed 1 year ago. Today, I would like to share a clinical case that clearly illustrates the rationale and the long-term effectiveness of the selective dorsal neurectomy in properly selected patients. The patient was a 32-year-old male who traveled to Istanbul from abroad with a primary complaint of lifelong premature ejaculation. His intravaginal ejaculation latency time was in the range of seconds. He described a complete lack of ejaculatory reflex control and extreme penile hypersensitivity, particularly at the glans penis. He had previously tried topical anesthetics, SSRIs, and behavioral techniques. These provided either temporary benefit or were discontinued due to side effects. In our initial evaluation, as with all patients, we didn't approach as a purely subjective complaint. We performed to this patient that detailed sexual history, neurological examination, objective sensory testing, including vibratory threshold assessments. The findings were consistent with the significant penile hypersensitivity. His sensory thresholds were markedly lower than the physiological norms and indicating exaggerated afferent dorsal nerve signaling. This distinction is really very important. Not all premature ejaculation is psychological. In a subset of patients, the underlying mechanism is a neurophysiological hyperexcitability. In such cases, simply suppressing the ejaculation centrally with medications does not address the peripheral primary driver. Indication for neurectomy for this patient based on objective hypersensitivity and failure of conservative treatments. The patient was considered as an appropriate candidate for neurectomy surgery. The goal of selective dorsal neurectomy is not a denervation. It is a selective neuromodulation process. During this procedure, specific dorsal nerve branches which is responsible for excessive sensor transmission, are microsurgically identified and selectively modified while preserving sufficient neural input to maintain normal erection and sensor function. The objective is physiological normalization, not the numbness. In our postoperative course, the postoperative period was uneventful. There were no erectile complications or no loss of sensation beyond expected modulation. No want-related issues were present. After resuming the sexual activity, the patient reported a significant improvement. His ejaculation latency time increased from seconds to a range between the 7 to 11 minutes. More importantly, he described that he restored control and reduced performance anxiety. From a functional perspective, this range is considered as physiologically normal and consistent with the improved ejaculatory regulation. Our 1 year follow-up period, approximately after 1 year, the patient returned to Turkey for an unrelated procedure, the hair transplant. You know, we are very famous with the hair transplant. At that time, we performed a follow-up evaluation for the patient. This provided a valuable opportunity to objectively reassess the long-term outcomes. We repeated the same sensory testing protocol. The findings were notable. The previous documented hypersensitivity was no longer present. Sensory thresholds were in normal physiological range, and there was no evidence of pathological hypoesthesia. Clinically, his ejaculation latency time remained stable in the 7 to 10 minutes range. This indicates not only symptomatic improvement, but the sustained neurophysiological modulation. This case highlights that several important points. The patient selection is really very critical. Secondly, the objective hypersensitivity should be documented. And thirdly, selective dorsal neurectomy shouldn't be considered as a first-line therapy. And fourthly, the goal is normalization, not elimination of sensation. When performed in the correct patient population, neurectomy can provide durable improvement by addressing the peripheral sensor driver of premature ejaculation. It is not a universal solution, but in carefully selected cases, it is a scientifically rational and clinically effective intervention. As a final perspective, premature ejaculation is a multifactorial disease. Psychological, central, neurochemical, and peripheral sensory mechanism may all contribute. Understanding which mechanism predominates in each patient is really very essential. In this patient, peripheral hypersensitivity was the primary factor. Selective dorsal neurectomy corrected the imbalance. 1 year later, both objective testing and clinical outcome confirmed that sustained normalization. That is the key point. Not suppression, not masking, but restoring the physiological balance.